And so I am going to introduce today's speaker. I have a great pleasure introducing Dr. Klar Yaggi, who is a professor of medicine at Yale. He's also a vice chief for research in the section of pulmonary critical care and sleep medicine. He's also a director of Yale Centers for Sleep Medicine. And so really pleased to have Klar with us. He received his bachelor degree in philosophy at Johns Hopkins University. And after considering fundamentals of life, he correctly chose a calling of a physician, which he pursued at Maryland for medical school and then Yale for residency and fellowship training. He's been at Yale ever since. So Klar, embodies an academic physician, a true triple threat. He works in the ICU, he works in the sleep clinic, and is an outstanding clinician. He is a thoughtful and kind educator and mentor. Many of his former fellow trainees are now young leaders in academic medicine, from the Mayo Clinic to Mount Sinai and other places. And Klar is also a gifted leader and administrator. His vision for the Yale Centers for Sleep Medicine has come to life with a center that sees over 6,000 patients per year, trains 4 sleep medicine fellows, educates the community about the sleep importance, and is a thriving resource for clinical research and translational research at Yale. And in the research domain, Klar has made significant contributions to our understanding of sleep apnea and its implications, specifically for stroke and cardiovascular disease. And he actually published a seminal paper in New England Journal that established sleep apnea as a modifiable risk factor for stroke as a fellow, no less. And since that time, he hasn't looked back and has gone on to publish over 100 original research articles that are peer-reviewed. And he is funded by multiple NIH and Yale grants, currently holds no less than 5 of those as a PI or co-I. And his most recent work is focused on the intersection between the fields of sleep and opioid use disorder. And so I'm excited to hear his talk on this topic today. But most importantly, Klar brings tremendous enthusiasm to the research and the education that he does, and is a very engaging speaker. And so let's welcome Klar and hear about the paradigms of recovery in sleep and opioid use disorder.
Wow, thank you so much, Andre. That was a very kind introduction. Let me just share my slides here. Can everyone see my screen? Okay, fantastic. Well, thank you again for that very kind introduction. I feel very fortunate to be doing what I'm doing at Yale, and just working with and collaborating with many gifted investigators really across different institutions, and was asked today to speak about some work and a topic that we've more recently become engaged with. And that is, as Andre indicated, the intersection between sleep deficiency, and opioid use disorder, which prior to the COVID pandemic was the major epidemic in this country. And today we're going to talk about opioid use disorder, sleep deficiency, some of its implications for ventilatory control, and some of the bidirectional mechanisms and novel therapeutic targets in this domain. I'm going to be talking briefly about 2 specific grants that I've been engaged with in this context. One is called the CLOUD study, and the other the OASIS study. And the objectives for this talk are to really highlight some of the bidirectional mechanisms between opioid use disorder, OUD, and sleep deficiency. We're going to then describe some of the efforts targeting sleep deficiency and control of breathing with therapeutic interventions to promote healthy recovery among patients with opioid use disorder. And at the very end, really talk about an actionable research agenda to better understand this relationship and develop novel therapeutic targets. And we're going to do this by really talking about opioid use disorder, just to put everyone on the same page. Talk about how sleep deficiency really occurs across the trajectory of this addiction, bidirectional mechanisms, some of the research work that's going on, and then interventions. So opioid, when we talk about a substance use disorder, the DSM-5 defines these criteria to include tolerance, withdrawal, increasing use, loss of control over use, craving, and social or functional impairment. And opioid use disorder, OUD, is really a subset of substance use disorder that is really characterized as a chronic and relapsing brain disorder that involves a loss of control over opioid use and coexisting deficits in cognitive function, mood, pain perception, and autonomic activity. Many of you have either read this book or seen the series Dope Sick. Opioids are now on pace to kill as many Americans in a decade as the entire HIV epidemic did since it began. The widespread use of opioids to treat acute and chronic pain contributed to approximately 10 million people in the United States who misuse opioids. It is a lifelong and typically relapse-filled disorder. 40 to 60% of patients who use opioids, non-prescribed opioids, can achieve remission with medication-assisted treatment or medication for opioid use disorder, but sustained remission takes up to 10 years or more. And meanwhile, about 4% of patients who use non-prescribed opioids die annually from overdose. There have really been sort of three major epidemic waves associated with our current state of opioid use disorder. One initially related to commonly prescribed opioids, in part related to movements to include pain as a fifth vital sign. These medications have significant potency and speed and intensity of pleasure. There was, as I think we're all aware, a downplay of the abuse potential by various drug companies and inappropriate marketing tactics that downplayed their abuse potential. In fact, they are very vulnerable to abuse. After that initial wave of commonly prescribed opioids for pain, there was a subsequent wave of a heroin epidemic. And now we're sort of in a period now where fentanyl is a predominant opioid involved in the opioid epidemic. What we know biologically in terms of our endogenous opioid system, it plays a central role in the regulation of mood and well-being and consists of three different G protein coupled receptors: the mu receptor, the delta receptor, the kappa receptor, which are stimulated by endogenous peptides, opioids, endogenous opioids. These receptors can also be activated exogenously by other opioids, such as morphine. What we also know is that morphine's analgesic and addictive properties are abolished in mice who lack the mu receptor, which really points to the mu opioid receptor as the key molecular player in some of the therapeutic and abuse effects associated with opioid use disorder. We have three different medications that are currently FDA approved to treat opioid use disorder, termed medications for opioid use disorder. And these include methadone, which is a full agonist of the mu receptor, buprenorphine, which is a partial agonist, and naltrexone, which is an antagonist of the mu receptor. We know that these medications and trials from these medications help to improve retention in outpatient treatment programs for opioid use disorder and also help to decrease the risk of overdose. They work by reducing craving, they treat withdrawal and block subsequent drugs, and really help patients return to a normal state of function. However, there is significant variability, particularly in retention in opioid treatment programs that use these medications for opioid use disorder, with just retention rates up in 6 months of 58%, and that continues to decline as time progresses. And after 2 or 3 years, only about a third of patients remain in opioid treatment programs. And the downside of that is when patients leave these MOUD programs, the rates of recurrent non-prescribed opioid use continue to go up significantly as the years progress. And so the clinical program is that there are effective evidence-based frontline treatments to treat opioid use disorder, but significant variability in those treatment responses. We know that relapse rates are high and associated with a lack of retention and treatment and a continued cycle of non-prescribed opioid use. And so there is a really important critical need to identify novel strategies and new approaches to complement and enhance medication for opioid use disorder therapies, improve retention and treatment, and reduce recurrent illicit opioid use that ultimately can lead to overdoses and death. And about 4 or 5 years ago, the NIH, and as I'll be talking about shortly, developed the HEAL initiative, which is an acronym that stands for Helping to End Addiction Long Term, which is an all hands on deck trans-institute approach to try to understand better some of the mechanisms involved in opioid use disorder and potentially develop novel treatment pathways. One of those promising pathways has to do with sleep, and the idea of targeting a neurobiologic system that could be potentially linked to opioid use disorder relapse, both sleep and circadian biology. Sleep deficiency, as we will talk about, is very common and often very severe among patients with opioid use disorder. And about 5 years ago, at a public meeting that the FDA coordinated that included patients with opioid use disorder, they identified sleep disturbance as a primary contributor to returning to non-prescribed opioids and treatment attrition. And so we're going to shift now and talk a little bit about how sleep deficiency occurs really across the trajectory of this disorder. And when we use the term sleep deficiency, the NHLBI defines this broader construct of sleep that involves several components. So one, of course, is sleep deprivation, simply not getting enough sleep or short sleep duration. We also speak about non-circadian sleep, so sleeping at the wrong time of day or sleep that is out of sync with our underlying circadian rhythm and abnormalities in sleep timing and sleep regularity. And then, of course, another component of this construct of sleep deficiency is impaired sleep quality. So not getting all of the different types and stages of sleep, so impaired sleep architecture, or having an underlying sleep disorder, such as sleep disordered breathing or insomnia that prevents us from getting enough sleep or contributes to poor quality of sleep. And what we know is that sleep deficiency really accompanies opioid use disorder throughout its trajectory. We know that social jet lag, so having a very large time difference between when we sleep during our work week compared to non-work days, and as well as delayed sleep phase syndrome have both been linked to addiction vulnerability, alcohol use, as well as opioid use. We know that patients who are undergoing and having symptoms of withdrawal or undergoing a supervised withdrawal protocol have significant impairments in sleep, with increases in sleep latency, decreases in total sleep time, impaired sleep quality, and a number of constitutional symptoms, GI symptoms, bone pain, hyperthermia, sweats and chills that also impair sleep and impair sleep quality. We all also know that even among patients who are plugged into opioid treatment programs and receiving medication for opioid use disorder, 70 to 85% of these patients report poor sleep quality. And also importantly, and this is a major concern to clinicians who care for patients in these outpatient treatment programs, up to 69 to 88% of patients in these programs are on some form of sedative, hypnotic, prescribed or unprescribed, to help with their sleep, either on benzodiazepines or some of the Z drugs or other over-the-counter sleep aids, just pointing to how prevalent sleep deficiency is, even in recovery programs. And of course, we know that opioid-related deaths can actually occur during sleep, where the constellation of the impairment and respiratory drive that occurs with sleep, superimposed with the respiratory drive impacts of opioids, decreases in control of breathing, can lead to respiratory failure and death. And so we're going to move now and talk a little bit about how sleep, how opioids may directly impact sleep, but also the reverse direction of causality, how sleep deficiency may be perpetuating and leading to worse outcomes among patients with opioid use disorder. And these are two pictures going back to Greek mythology that speak to this sort of long history between sleep and opioids. So on the left panel is Hypnos, who is the god of sleep, who is flying through the night with his mother, Nyct, the goddess of night, and actually inducing sleep by spreading poppies over the earth to induce sleep. And Hypnos's son, Morpheus, is the god of dreams, and from which the term morphine is derived. So there was a long history of this context between opioids and sleep. But paradoxically, rather than promoting dreams and promoting sleep, we know particularly that acute opioid use actually does just the opposite. It increases wake time, it reduces slow wave sleep, it increases lighter stages of sleep, really in a dose dependent manner. And this is attenuated somewhat with chronic use. And we know that opioids, in addition to impairing sleep architecture, can have significant impacts on some of the domains of our ventilatory control system. So we have three basic components of ventilatory control: the controller, which involves both the cortex and pons and medulla; our sensors in the ventilatory control system, which are located in the carotid and aortic bodies, and some stretch receptors within the lung; and then certainly the effectors of our ventilatory control system, which include the diaphragm and some of our accessory muscles of respiration, and even some of the upper airway muscles to maintain patency. And as we'll talk about, opioids can impact each of these domains of ventilatory control. And one of the first examples of this is a form of ataxic breathing associated with opioid use, termed Biot's respiration, described by Camille Biot, often somewhat dose dependent. So the higher the dose, the more likelihood, the appearance of this ataxic breathing. But it's really described as having periods of bradypnea, so a very slow breathing rate with intervening periods of central apnea, and sort of an erratic pattern of breathing. In addition to contributing this to this ataxic breathing pattern, we know that there really is sort of a dose dependent in terms of morphine equivalence of an association between sleep apnea and opioid use. And this is particularly true when we look at this in terms of types of events. There is a very strong dose-dependent effect of opioid use with the development of central apneas, but also obstructive events, including obstructive apneas and obstructive hypopneas. So the interesting thing, and this is a recent paper by Gavidia et al., is that there is certainly an increase in the risk for the development of central sleep apnea with opioid use. But what we also know is that when we combine opioids with other sedative hypnotics, myorelaxants, baclofen, other centrally acting antidepressants, even antihistamines, certainly benzodiazepines and some of the Z drugs, the risk for central sleep apnea jumps considerably when you add these medications, as commonly occurs in MOUD programs where you're on a partial agonist or full agonist to help prevent the withdrawal symptoms, and concurrently taking medication to help with sleep at night. We are beginning to understand that opioids can directly impact a number of domains of the physiologic traits of sleep apnea. Certainly, pharyngeal dial muscle function, impacts on arousal threshold, ventilatory controlled, these sort of three important physiologic traits for the development of obstructive sleep apnea, not just central sleep apnea. But it's not as clear as just opioids' impact on some of our physiologic traits for sleep disorder breathing. Tipping the scale into the development of sleep disorder breathing likely involves a number of influential factors besides these OSA or sleep apnea endotypes, to include how patients metabolize and the pharmacokinetics of these drugs in individual patients, how prevalent sleep deficiency is in individual patients, other comorbidities, body habitus and position, age and sex also likely play a role in terms of tipping this balance into clinically significant sleep disorder breathing in patients. In addition to these sort of direct impacts of opioids on sleep architecture, on our control system, on increasing the risk for both obstructive and central sleep apnea, we also believe that there are mechanisms going the other way, whereby sleep deficiency may lead to worse outcomes or even perpetuating opioid use disorder. And we're going to briefly talk about some of those mechanisms that include some common and overlapping neurocognitive pathways involved in addiction that also occur with impaired sleep. We're going to talk a little bit about the role of the orexin system and also neuropsychiatric mechanisms, how stress, pain, mood, other substance use that often co-occurs with sleep deficiency may be impacting outcomes in patients with opioid use disorder in terms of recurrent non-prescribed opioid use, addiction severity, functioning, and quality of life. One of the things that got us interested in this domain of investigation is that some of the same neurocognitive mechanisms that are involved in addiction in general, but opioid addiction in particular, including executive function, reward processing, incentive salience, the tendency to binge, are also impaired in sleep deficiency. So we know that repeated drug exposure can affect these circuits in the prefrontal cortex, which is our domain of executive function, the amygdala, which impacts reward and negative affect, in the basal ganglia, incentive salience. And all of these domains sort of correlate neuroanatomically to the three-stage cycle of intoxication, withdrawal symptoms, and craving, each corresponding to these brain syndromes. And these same brain regions and circuits are impaired in patients with sleep deficiency as well. Where I think many of us are aware in sleep medicine of the orexin or hypocretin system, which are neurons located in the lateral hypothalamus that actually have inputs from both sleep and our circadian rhythmicity. A deficit or a loss in the neurons that produce orexin is a known cause of type 1 narcolepsy, where sleep intrudes into wakefulness. But we also know that increasing orexin contributes to arousal, sleep disturbance, stress signaling, and drug seeking. Orexin neurons also have projections into the reward system of the brain. And there's some preclinical evidence that blocking these receptors and neurons helps to attenuate withdrawal and drug seeking. So more on this in a little bit. And the NIDA, the National Institute of Drug Abuse, listed the dual orexin receptor antagonists. So suvorexant, levorexant, doritorexant, one of the new Belsomra, for example, one of the drugs that we know helps to treat insomnia, also may have some really helpful effects on preventing some of the symptoms of addiction and withdrawal and drug seeking. And NIDA listed these drugs as one of the 10 most wanted medications to develop in this population of patients. Another system that is likely involved in the potential relationship between sleep deficiency and worse outcomes among patients with opioid use disorder is our stress system. So we know sleep deficiency activates both short-term immediate stress pathways that result in the production of catecholamines, but also prolonged stress pathways that cause the adrenal cortex to release mineralocorticoids and glucocorticoids. We know that sleep deficiency leads to heightened blood pressure, increases in sympathetic activation, increases in catechols and cortisol. And acute and chronic stress are also associated with the progression of opioid use disorder and contribute to relapse in patients with opioid use disorder. So there's possible some bidirectional and mutually reinforcing pathways that involve stress and sleep and opioid use disorder. Mood is also probably another potential pathway here. We know that among adults with mood disorders, sleep deficiency is associated with worse cognitive functioning and may contribute to suicidality. And we are really, I think, starting to shift away from thinking about sleep deficiency just as an epiphenomenon of depression, and thinking much more about viewing it as perhaps an important and under-recognized mechanism of depression that may lead to adverse health outcomes. And certainly ongoing mood disorders, particularly among patients with opioid use disorder, results have poor retention in clinics and lower quality of life. I think another pathway involved here between sleep deficiency and worse outcomes in patients with opioid use disorder has to do with this sort of vicious cycle of sleep pain, which many patients with opioid use disorder have, is actually part of the definition of opioid use disorder, and dose escalation of opioid use. So we know pain can certainly impair sleep and disrupt sleep. We know in particular that sleep deficiency helps to produce a hyperalgesic state. And so we can get into this vicious cycle of opioids actually impairing sleep, impaired sleep, lowering pain threshold, more pain leading to greater opioid use, all involving sleep in this cycle. And certainly patients who have opioid use disorder, there's an influence of other medications and other substance use that can impair sleep. We know that mu receptor agonists, precisely the medications that we are using, that the FDA has approved to treat opioid use disorders, themselves directly inhibit REM sleep and slow wave sleep, attenuate sleep quantity and quality, and may in themselves predispose to sleep disorder breathing, as we mentioned, particularly when other sedatives are used in conjunction. Many patients with this disorder also use nicotine, which lengthens sleep onset, decreases total sleep duration, particularly deeper sleep stages. Many of these patients also consume alcohol, which is a depressant initially, but as it's metabolized, I think as we're all aware, can actually become quite activating and significantly disrupt the second half of the sleep period. And then finally, there are likely some social ecologic mechanisms and factors that track with opioid use disorder that themselves lead to, and we can think of these in terms of societal level factors, racism, discrimination, stigma, social level factors, neighborhood level factors, race, ethnicity, social networks, and certainly individual level factors that track with opioid use disorder that may be contributing to sleep disruption. So with that, some background, I want to briefly mention a couple of studies that we have become involved with to try to get at some of these mechanistic pathways and try to understand what may be important predictors of sleep in terms of worsening opioid use disorder. One of those studies is called the CLOUD study, which is a collaboration linking opioid use disorder and sleep. And this is a large observational cohort study of about 220 patients that we have just literally finished recruitment and follow-up on. We're recruiting patients out of a clinic in New Haven called the App Foundation, which is an open clinic that serves New Haven, West Haven, and North Haven, and provides medication for opioid use disorder. These patients undergo, have recently, we enroll these patients after they've been recently stabilized on medication for opioid use disorder. And we do a cadre of baseline assessments, including very detailed sleep and circadian assessment with measures of melatonin and polysomnography and actigraphy. They're undergoing functional magnetic resonance imaging to understand some of these connections and pathways in the brain that may overlap with sleep deficiency and opioid use disorder, a full neuropsychiatric assessment, and even some environmental and psychosocial and family measures at baseline. These patients are then followed over a 6-month period of time for a primary outcome of looking at recurrent non-prescribed opioid use, but we're also looking at various measures of retention in clinic and social functioning, et cetera. And so this is a basic schema of the study. So our first aim is to look at some of these neurocognitive mechanisms, largely through fMRI testing, aim one, and how those may relate to adverse outcomes in patients with opioid use disorder. Our second aim is to explore some of these same pathways that I've described: chronic stress, pain, mood, and how those may be mediators of the relationship between sleep deficiency and outcomes. And then finally, we're looking at some of these social ecologic mechanisms at the individual home, family, neighborhood, and community factors that may be contributing to sleep deficiency. And in particular, focusing on some of these known cognitive pathways, and a real interest in thinking about how pain is involved in this relationship between sleep and adverse outcomes. A sort of a sister study to the CLOUD study is a larger cohort study called OASIS, which is Opioid Use and Sleep Intersection Study, which is formed from 4 or 5 other more mechanistic studies, such as CLOUDS from the University of Alabama, from the University of Pittsburgh, Hopkins, Brown, Harvard, as well as Yale, all funded under this HEAL initiative. And where these individual studies at each of these sites are designed to look at some potential mechanisms of this relationship between sleep and opioid use disorder. These individual studies are all contributing to a larger cohort study, a common protocol to look at sleep predictors of recurrent opioid use and retention in clinic. So we're now going to shift to finish up by talking about some work that has been done in looking at how targeting sleep deficiency with various types of interventions may actually help us to improve outcomes among patients with opioid use disorder. And there has been some work in particular looking at CBTI, cognitive behavioral therapy for insomnia in patients with opioid use disorder. CBTI is just one specific form of cognitive behavioral therapy. There's CBT for pain and depression. And so there is sort of an overlap of cognitive behavioral therapy already present and occurring in patients with opioid use disorder through these outpatient treatment programs. I think many of us are familiar with the Spielman's 3P model, the predisposing, precipitating, and perpetuating factors of insomnia, and that CBTI really is targeting some of these maladaptive coping, cognitive, and arousal mechanisms that occur with insomnia. We know that CBTI is a first-line treatment for insomnia in general. It helps to consolidate sleep. There are, as we mentioned, some possibly overlapping benefits with CBT for chronic pain or CBT for substance use disorder, has a very low risk of harm, and in fact doesn't involve other drugs with abuse potential, particularly benzodiazepines. And a few studies have looked at this and have demonstrated significant improvement in things like the Pisky score, specifically among patients with opioid use disorder. So overall, it's shown promise for opioid use disorder and some other substance use disorders, but much more studies are needed to better understand the appropriate delivery mechanisms of CBTI in this population, and how this may not only improve insomnia, but may impact key outcomes of patients with opioid use disorder. There have been a select number of studies looking at various sedative hypnotics to treat insomnia in opioid use disorder as well. There's no benefit associated with using trazodone in these patients. There was some benefit, particularly with mirtazapine, in terms of improving total sleep time, sleep onset latency, sleep efficiency, more so than when combined with zolpidem or with zolpidem alone. Melatonin may help to improve sleep quality and depression in this population. Quetiapine improves insomnia, may help with opioid craving. I want to focus a little bit on suvorexant, because this is a very hot topic in the field of sleep and addiction right now. And there's some preliminary data, both from animals and now even through some work that Andrew Hune has done, that this drug both helps to improve total sleep time, improve REM sleep, and simultaneously treat addiction, opioid withdrawal symptoms, opioid severity and craving, in this particular case during a buprenorphine taper. And so the orexin system and what dual orexin receptors target are the orexin receptor 1 and orexin receptor 2. So targeting orexin receptor 2 is needed to treat insomnia, and orexin receptor 1 antagonist actually helps to attenuate drug-seeking behaviors. And some very potent animal work showing that this helps to reduce heroin self-administration, oxycodone seeking, fentanyl seeking, and so somewhat of a really intriguing possibility of a drug that can simultaneously help to treat the sleep deficiency and insomnia in this population and help with the addiction, and works via non-benzodiazepine pathways, so doesn't carry some of the side effects, particularly addiction side effects associated with those drugs. And there are a large number of clinical trials underway right now, some of which we're participating in to help see if this could be a really helpful drug in this population of patients. So in addition to CBT and some of the pharmacologic agents we just talked about, certainly PAP studies have been done in this population using a variety of different forms of positive airway pressure. And I list some of the main studies here. What we have gleaned from these studies that involve CPAP, BiPAP, BiPAP-ST, and ASV is that it seems that BiPAP, particularly with a backup rate, appears to be more effective than CPAP alone. And in a select number of trials, ASV even seems to be superior to bi-level ST therapy. And this was shown in a couple of papers, actually, from Javahari and al. Although ASV was actually designed more for Cheyne-Stokes physiology, it seems to be very helpful in at least the central, treating the central apnea associated with opioid use disorder, more so than other forms of PAP therapy. And there have been a couple of lessons learned from a number of these studies on PAP therapy for opioid-induced sleep disorder breathing, both both obstructive and central sleep apnea. And one of those lessons in a systematic review of some of these studies is that if you see ataxic breathing on a polysomnogram of these patients, biopsy respiration, that's really a very poor predictor of response to any form of PAP therapy. So whereas ASV and BiPAP-ST can be very helpful, even in central sleep apnea, when we see this ataxic breathing, patients don't seem to tolerate PAP therapy very well. There is some conflicting data on the impact of CPAP in the management of opioid-related sleep disorder breathing. One study noticed an increase in central events. Another study that used CPAP together with oxygen actually showed a reduction in central events. BiPAP without a backup rate actually increases central events, as would be expected. ASV appears to be more effective than BiPAP-ST among patients with chronic opioid use. But there's really no studies looking at the impact of these devices on measures of quality of life and other important outcomes, such as recurrent use and retention in clinic and mortality in this population of patients. So in addition to PAP therapy, there's some really intriguing novel respiratory stimulants that are being tested, at least in some animal studies, that may, in fact, have some therapeutic benefit down the line in humans. And I want to highlight a couple of these. One is a group of drugs called the ampakines that activate AMPA-glutamate receptors, which we'll talk a little bit. But there are a number of therapies that have the potential to sort of counteract some of the respiratory depression associated with opioids, either at the level of the controller, the sensors, or the effector muscles of our ventilatory pump. And so I want to talk about this class of drugs called the ampakines. Opioids, we know, induce respiratory depression. They also reduce hypoglossal nerve activity, and it's a real and predisposing to sleep apnea. And these drugs actually help to attenuate that. They counteract the opioid receptor-mediated respiratory depression associated with opioids, work on the controller of the ventilatory control system. And so they offer promise as a potential pathway to preventing some of the unwanted sleep disorder breathing and respiratory depression associated with opioid use. This is certainly not ready for prime time, but encouraging that there are some pharmacologic options that are being developed. Another domain of interest clinically is intranasal leptin, which can augment the hypercapnic and hypoxic chemosensitivity. So really at the sensor level of our control of breathing, help again to prevent opioid-induced sleep disorder breathing, and certainly some effectiveness that has been demonstrated in mouth models, but this has not yet been translated to humans, but again, holds the potential to potentially come up with a therapeutic intervention that may help to minimize some of the respiratory depression, hypoventilation, and sleep disorder breathing associated with opioids. And then finally, I'll just end by just sharing some thoughts on what are some of the gaps. This is a very young, despite the Greek mythology linkages between opioids and sleep, this is really a relatively young domain of investigation. And there are some really key areas that I think we need to better understand that may potentially benefit patients with opioid use disorder in this epidemic that is occurring, not just in the United States, but around the world. So better understanding some of the mechanisms by which sleep deficiency may contribute to opioid use disorder. What are some of the key measures of sleep that, or sleep disorder breathing and metrics that may potentially predict whether someone is going to recurrently use non-prescribed opioids or drop out of treatment programs. The impact of how some of the treatments that I alluded to, both pharmacologic and non-pharmacologic strategies, might help to improve outcomes, not just sleep, but outcomes in patients with opioid use disorder. We really need biomarkers in this area, better biomarkers, and perhaps some polysomnographic measures that are going to be predictive in the future. More work, certainly in the domain of some of the physiologic traits of obstructive sleep apnea, the endotypes, how sleep deficiency impacts some of the addiction brain circuits, the impact of cognitive behavioral therapy on outcomes in opioid use disorder. Very limited work so far on chronobiologic therapies and addiction vulnerability, but some studies now starting to at least measure this and look at linkages between circadian rhythmicity and addiction. I mentioned and highlighted, I think, this really potentially novel drug, the DORA receptors, the DORA and dual orexin receptor antagonist that treats both sleep and addiction simultaneously, may really, hopefully, some of these clinical trials are going to show some benefit in this population, because we really need some better interventions. And I think I mentioned at the end here some of the newer but not quite ready for prime time respiratory stimulant pharmacotherapies that may help to counteract some of the respiratory depression and opioid-induced sleep disorder breathing that occurs in this population. So just to summarize, we've talked about how sleep deficiency really occurs across the OUD trajectory. We've talked about how social jet lag and delayed sleep phase increase addiction potential, how severe sleep disturbance it is in patients undergoing withdrawal, the high prevalence of sleep deficiency, even among patients in recovery receiving medication for opioid use disorder, and that many opioids may contribute to deaths, in part through its suppression of ventilatory control during sleep. We talked about the sort of bi-directional pathways here that opioids have on sleep, direct effects on sleep architecture, control of breathing in the form of biopsy respiration, central obstructive sleep apnea. But there are also pathways by which sleep deficiency may be worsening outcomes in patients with OUD. And we talked about some of the neurocognitive mechanisms, the orexin system's involvement as a player, neuropsychiatric mechanisms, and even some of the social ecologic mechanisms and linkages to sleep. And finally, there's some really promising potential treatments to intervene on these patients in terms of looking at the DORA's impact on sleep, various forms of positive airway pressure, and some of these newer respiratory stimulus. Much of what I just talked about today is in a recently published review that I did with Danny Eckert that was published in the Blue Journal in 2022. So please, if you'd like to get some more information on this topic, please feel free to look at that paper. And just want to acknowledge and thank many of the collaborators who I've been getting this work with in opioid use disorder here at Yale through the CLOUD study, but also this larger cohort study that the NIH is now supporting through the HEAL initiative to look at predictors of sleep and develop prediction models that help us better understand which patients may relapse and which patients may not follow up and drop out of treatment. So with that, I will stop and hopefully have a few minutes for questions. Thank you very much.
All right. Well, very very nice overview and tour de force through the relationship between sleep and opioids and opiate use disorder. And so we do have a couple of questions in the chat, and I have a few of my own. But let's start with Dr. Rue, who is asking, which therapy might be best in patients who have combined OUD and PTSD?
I think the that is a really interesting question, because that's also obviously a mutually reinforcing relationship. We know certainly the sleep apnea can activate the sympathetic nervous system, and activating the sympathetic nervous system is a key component of PTSD. I think particularly in patients who have both, you really have to treat both. And we have a lot of experience with that, as many of us are aware of, in caring for our patients at the VA. And so there's a significant overlap. I think there are a number of therapies, counseling therapies that have shown benefit. I think there was some promise with using some of the alpha and antagonists. I think they're still being used, but I think you really have to treat both, Francoise, simultaneously.
Great. Oh, thanks,
Thank
Klar.
you. A wonderful talk, Klar. It was great.
Thank you, Francoise.
All right, Dr. Johnson has a question. Dr. Johnson, you want to just ask it? I'll unmute you.
No, sure. So needless to say, I'm getting all these difficult restless leg patients, and with the not trying to use dopamine agonists, the question comes up more and more often about whether to use opiates. And I, potentially, in theory, try to do the Suboxone methadone, but I have all these people that start vomiting and horrible headaches and feel horrible. So now it's, do you put them on more traditional opiates, which for all the reasons you described,
Right.
I don't like any of them, but what do you think?
That is a great question.
Try the low dose.
Yeah. No, but my answer
We'll
to
bring Brian in here.
That's right. My answer to that question is refer them to Dr. Brian Koo, who
I could shed some light on this issue.
Yeah,
So,
that would be helpful, Brian. Thank you.
John Winkelman has an R21 that just ended to use dopamine agonists, particularly pramipexole, in the setting of acute opioid use disorder detoxification. And so while the data is not complete, the hypothesis is that, well, we know from some of his work that restless legs is very common in people with acute again, I don't know the terminology, but who basically have opioid use disorder and chronic opioid use disorder and are undergoing and trying to get off the opioids. And so they can have severe restless legs, and pramipexole is a great drug acutely, so when you're undergoing detox, obviously you're suffering in an acute kind of way. So, he's testing the use of that drug specifically during this time. So whether or not that drug should be continued more than a few weeks is an open question. But I think it's fair to consider the use of those over opioids for obvious, for somewhat obvious reasons in this population.
Great, thank you. And let's see. So we have one more question from Dr. Trishita, and so she's grateful for an amazing talk. And her question has to do with excessive daytime sleepiness in somebody who has been on high doses of methadone and has no detectable sleep disorder breathing on testing and has ongoing EDS. And so what can we do to promote wakefulness in individuals if coming off the opioids is not an option?
Oh, that's a great question. All these are tricky.
Way beyond the data and evidence available to answer these questions.
No, but I think it raises the question of whether some of our wake promoting medications could have some utility in this population. So I think the focus of this talk was, hey, let's recognize sleep deficiency and its role in this population, where there are some tools that could be targeted for various sleep disorders and sleep deficiency. But I think what is being brought up is, in the absence of underlying real sleep disorders, managing the symptom itself of sleepiness and how that might be contributing to maybe recurrent use, and whether use of things like some of our stimulants. Certainly we want to try to avoid in this population, I would think, things with a significant addiction potential, amphetamines and so forth. But whether something like modafinil or armodafinil may play a role. There was a neuroinvestigator at Yale a number of years ago who was studying that, in fact, in patients with another substance use disorder, which was use of cocaine, and had some actually interesting and potentially clinically useful results. But this sort of speaks, I think, a little bit to how underexamined these questions are in this field. But I think a really interesting idea.
Yeah, I just want to underscore that the Yale Office of Continuous Medical Education does not endorse use of cocaine for wakefulness promotion in individuals with opioid use.
This is being recorded, correct?
just got to make it clear. Yeah.
That's good.
Okay. All right. And so I guess I'll ask one more question. And, in some ways, the mechanisms of addictive behavior with opioids may extend to, say, binging eating behavior in the evenings, especially in those people who are sleep deprived. And can you comment on potential use of DORAs in this kind of setting, or is there any data to suggest that the DORAs may inhibit other sort of impulsive behaviors?
Yes, there is, in fact. And I think you bring up a really interesting question, Andre. Not necessarily linking everything to orexin and DORAs, but certainly eating and other addictions have been linked to that neurotransmitter system. But I think what we're also observing and seeing some preliminary data on are things like some anecdotal evidence from some of the GLP-1s that are being used right now for weight loss, and that they have maybe some overlap with other addictions themselves. So in addition to promoting satiety and appetite suppression, I think there's some anecdotal evidence among patients who have struggled with various addiction disorders that they feel less inclined to using. So some of these drugs are just, I think, are tapping into intersecting pathways within the brain that are simultaneously affecting, eating and satiety and addiction and so forth. And perhaps we'll even see some of these drugs that we're targeting for obesity and weight gain used in the future and as addiction treatments. But that's a great question.
All right. Well, thank you very much, Klar. Thank you very much, the audience, for wonderful questions. Turns out to be another excellent edition of the New England Combined Sleep Seminar. And so we will see you in 1 month's time. Enjoy the early spring, and we'll see you then.
Okay. Thank you.
Take care.